Um, my name is Zoe Mushcat. I'm the health psychology intern at Jesse Brown VA. On behalf of Northwestern University's Feinberg School of Medicine and the Jesse Brown VA Medical Center in Chicago, I'm welcoming you all to our next presentation of the 2020 Health Psychology Seminar Series. We have a great lineup of health psychologists, and our presentations will occur most Wednesdays at 2:30 p.m. Central Time through December 2nd. For those of us attending our live presentation today, we're very glad that you could join us. And just type in the chat box where you're coming from and what program you're in so we can get a sense of who tunes in. You can also type questions into the chat box throughout the talk, and then we will relay them to our speaker at the end of the presentation. And just make sure before we get started that your microphone is muted. I'm honored to introduce Dr. Allison Carroll, Research Assistant and Professor of Psychology of Psychiatry and Behavioral Medicine at Northwestern University's Feinberg School of Medicine. And Dr. Carroll received her PhD from Northwestern. She completed her internship at the Medical University of South Carolina and her postdoctoral fellowship at Bloom Cardiovascular Institute at Northwestern. Dr. Carroll's research currently focuses on implementing behavioral health interventions in systems within the community. Her research has also examined the synergistic effects of comorbid health conditions, behavioral and psychological risk factors, and their effects on cardiovascular disease. Today, we're thrilled to welcome Dr. Carroll to present on cardiac behavioral medicine.
Great. Thank you so much, Zoe, and thank you, everyone, for tuning in and for inviting me back. This is especially exciting for me because I was actually an extern at Jesse Brown VA and organized this series back in the day, so it's really great to see how it's evolved and has a much broader reach. It's excellent. So, which actually I was asked to speak a little bit about my background and kind of how I got into cardiac behavioral medicine. So after graduating undergrad, didn't have enough research experience, so I went and did a post-baccalaureate research experience at the National Institute on Drug Abuse, studying smoking and neuroimaging of smokers' brains while they were smoking or not smoking. That was not clinical enough for me. That was too far removed, really, from any sort of practical helping somebody that I really wanted to get into. So I pursued clinical psychology training, and I knew that I wanted that background in health psychology. I was really interested in helping people learn how to change behaviors in order to improve their well-being, both physically and psychologically. So as you mentioned, I went to Northwestern University's clinical psychology program at the Feinberg School of Medicine, which was a really great place to train in being in an academic medical setting. It's very different, I've learned over the years, but for me, it was just really the perfect fit. And all throughout my clinical training, I had these opportunities that I sought out to really be able to engage in research, and this particularly the type of research that I wanted to do of quality improvement and program evaluations, working with these medical groups. And even when I was at the VA on my externship, I was able to really seek out the clinical and research experiences with cardiac populations, for example. So I would just really encourage you all, that's my biggest piece of advice, is that there's usually a way to get into doing some piece of what you want, and just being open to identifying those opportunities while you're in those moments. So, and then I did go to my postdoc training, which I finished this past year in cardiac behavioral medicine and have since transitioned into a research assistant professor position at Northwestern, more focused on implementation science, where I'm still able to look at those cardiovascular outcomes. So at risk of dragging this on too long, if anybody has any questions about the training process or experience, I'm always more than happy to talk through that. So thank you all again for having me. I don't have any formal disclosures. The only thing is that I do really like these heart and brain comments. So if you haven't seen them before, they are wonderful and lovely. And there's so many other organs. I would highly encourage you to check them out as health psychologists. I'm sure you can find something that fits for you. And this one in particular, I really enjoy because I really am much more about mindfulness and acceptance and commitment therapy in my approach to practice, especially working with medical populations. So what I'm going to touch on today, if hopefully I can get through everything, this is my plan, is starting with just an overview of what is cardiac behavioral medicine, how is it maybe a little bit different than working with other medical populations. We'll talk a little bit about the different cardiac populations you might be expected to work with in this setting, and in particular, how certain health behaviors and psychological factors play into the health and well-being of cardiac patients. And then the last bit, I'll really get into when you're working with patients, how to, again, the specific aspects of psychosocial assessment and treatment that pertain particularly to cardiac populations. But of course, so much of this is going to apply really broadly across other, working with other populations, other chronic disease populations. So like I said, of course, this is the plan, but this is something I'm really excited about. I can always get stuck on something or another, and if I'm happy to answer questions, and we'll try to make sure that I'm staying on track. Okay. As health psychologists and health psychology trainees, I don't think I need to tell you too much about this. I'm probably preaching to the choir a little bit, that we all understand that it's really important and useful and helpful to have psychologists in all sorts of clinic and medical settings, right? Cardiovascular disease, or CVD in particular, is highly prevalent. More than half of the US adult population has some form of cardiovascular disease. And we don't always think about that, in part because hypertension is considered a cardiovascular disease in most circles, because it is so highly associated with developing worse conditions down the road. And having poor blood pressure control can lead to really poor outcomes. And this, of course, leads to really high healthcare costs. And cardiovascular disease ends up being responsible for about 25% of deaths in the United States each year. And this is consistent for both men and women, a little bit higher in men. And where health psychologists fit in, you can see that these are the 7 components of cardiovascular health that were developed in 2010 by the American Heart Association, where the green bars show you the proportion of the population that meets the ideal criteria for each of these different behaviors. And they really are, 4 of them are behaviors, 3 of them are clinical factors. And of course, we work with smoking, we work on diet, we work on physical activity, body weight management, and also management of diseases such as diabetes, high cholesterol, and blood pressure. So you can see that there's a lot of red and yellow on there, where we have the opportunity to help out and work with these patients before they even develop cardiovascular disease. And what's interesting about this paper, too, is they showed projections. These are data from 2006, and they showed projections out through 2020 to see if we were going to meet the American Heart Association's projection or mission for 2020. And in current trends, they were nowhere close. So there's a lot of opportunities here for health psychologists. And likewise, psychological conditions, your depression, your anxiety, your schizophrenia, bipolar, are all associated with onset of cardiovascular disease. So having depression when you're young, in particular, can lead to cardiovascular disease down the road. So again, this is probably more psychologists in general, but health psychologists in particular, just knowing that when you're working with a patient in the general population, that you're also helping to prevent cardiovascular disease down the road. So just to kind of put this all in a nice package, there is a high prevalence of poor health behaviors in the general population and amongst cardiac patients as well. And these tend to cluster, which, as we know, makes it a lot more difficult to disentangle and really work on addressing all of them at once. There's a lot of depression, stress, and anxiety that not only contribute to the disease, but can be caused by the disease. Again, not necessarily specific to cardiac populations, of course. And there are ways that they've shown that psychological interventions can have their effect on heart disease in terms of course, facilitating those health-promoting behaviors, working with adherence in particular, helping the patient to manage and cope with having a chronic disease, and really understanding how they can deal with this, both behaviorally and psychologically and socially, and understanding the direct effects of these biological factors that through therapy can be mitigated that otherwise would influence the onset and progress of cardiovascular disease. if you are interested, I highly recommend these references. The new psychological treatment of cardiac patients actually just came out last year. It's a nice, like, thin, kind of quick guide with really useful information. And if anybody needs these references later, I can, of course, provide them. Okay. I also think it's really important. So like I mentioned, with the prevalence of cardiovascular disease, that includes hypertension. And we wouldn't necessarily normally think about hypertension as being a chronic cardiovascular disease that as health psychologists, we might be working with that. And so I want to just give an overview quickly of what we're talking about when we're thinking about these cardiac populations. So just visualize for yourself for a moment. What are you thinking of? Who are you thinking of when you hear of cardiac patients or someone who has cardiovascular disease or cardiac or heart disease? There's a whole variety, right? Like, we think about the person who falls down of a heart attack, they're clutching their left arm. We might see someone hooked up to EKG machines to measure heart rate patterns, and we might often think of older people. But of course, we know that if over half of the population has cardiovascular disease, it's not all older people. Like, that's 50% of the population who's 20 and older. So there's a lot of, there's just so much different opportunities here for us. Cardiovascular disease is interesting because we think about it in terms of the plumbing and the electrical problems. So you can imagine the heart in general is like a house. It's really powering everything else that's going on in the body. And the plumbing is when there's poor pressure or clogged pipes in the arteries, that of course can cause problems. Versus the electricity, you know, if you have faulty light switches or flickering light bulbs or bursts of power or blown fuses with the heartbeat, right? There's so many different ways in which that can go wrong, and are, again, so many different ways that these sorts of problems can be addressed medically. And there are a variety of different cardiac diagnoses and syndromes to think about. Again, I've mentioned hypertension a couple of times, getting down to heart disease or coronary artery disease. So I'm not sure if anybody here knows somebody with a cardiac diagnosis, but you might have heard of coronary artery disease and coronary heart disease. And what's interesting, those are the same thing. The only difference is that coronary artery disease, so this like blew my mind when I first heard about it, because I'd heard both, and they just seem to be used differently. Coronary artery disease is really about the physiology, that it's something that's occurring in the arteries, versus coronary heart disease is about the clinical picture. And this is one of those things that I just really love about being a health psychologist and working in medical settings, is learning these medical terminology where you can talk with both the physicians and the patients about the differences, or talking about the clinical picture and knowing how to present things differently. It's a little bit like speaking a different type of language. So these are the four that I really want to focus on. And I actually also want to mention heart failure as thinking about terminology. Someone can have heart failure without having any symptoms. And when somebody is told that their main organ that is keeping them alive is failing, that can be really, really psychologically distressing. That's something that even just talking about what the term heart failure means, that it's just medical terminology, right? It's not really about the clinical picture. It means the heart isn't as strong as it was. It means that it might be a little bit more lax than it used to be, but it's still in there, it's pumping. Somebody can be at 20% of their pump capacity of the heart and doing not great, but okay, right? And so working with people around coping, even just with having a name that's so hard to hear, that my heart is failing, like how am I not dropping dead if my heart is failing? And helping patients to understand what that actually means and how that's just talking a little bit more about the treatment that's going to be needed and potential down the road therapies. But arrhythmias, valvular diseases, heart disease, and heart failure are really kind of the focus of what I worked with while I was working clinically. We didn't see, I mean, obviously some people with congenital heart diseases might develop cardiovascular disease or heart failure down the road, same with vascular diseases. But really, those four are kind of the bread and butter of what you're going to be seeing when you're working on either on the inpatient unit or with outpatient cardiac patients. The other thing I'd just like to point out is the huge variety of treatment options that exist for cardiac problems. Of course, there's medications, which come with side effects. So diuretics, if you are having to get water weight off, and so people are peeing all the time, they're not great about adhering to that, especially if they have a long drive to get to your hospital. Beta blockers, you often need more than one. And so try to get a patient to take one pill a day, much less 2 or 3, just to treat one problem, because it can be really difficult to manage or control. There's various devices that might be used, an ICD to shock the heart into a regular rhythm if needed, or a pacemaker that's on all the time to keep the heart beating in a rhythm that's useful and helpful for it. There's all sorts of different levels of imaging that a patient might have to go through. So if somebody needs to have an MRI, you need to consider things like claustrophobia. And if they're going in for a catheterization, sometimes they might be under like twilight anesthesia, but sometimes they're not. And there might be something going into their neck or in through their groin to go and image the heart. And these can be really traumatizing for patients if they have to do it over and over and over again. And then, of course, there's various procedures. So this goes from something where the patient can be awake all the way to having a full-on open heart surgery. There's been a ton of advances in this field where they can do, instead of going in and doing a sternotomy where they cut open the chest, they can do a thoracotomy that goes in through the side. And so that is huge just in terms of patients' conceptualization of how traumatic this is going to be. And it also does significantly impact how quickly they're able to recover. If they're able to go in through the side, they don't have nearly as many limitations. They can recover much more quickly than if they have to go in through the sternum. And then, of course, we get into advanced heart failure therapies, somebody whose heart is failing so much that they might need a heart transplant, or they might need a ventricular assist device or a VAD, which is a heart pump that also has an external component to it. I can talk a little bit more about that if we're interested, but I want to keep moving forward. Okay, so health behaviors in this population. So I've already talked a little bit about, of course, health behaviors can put people at risk for developing cardiovascular disease, but it's also obviously important when somebody's already been diagnosed with cardiovascular disease. And this cartoon says here that to prevent a heart attack, all you need to do is just take 1 aspirin every day, then take it out for a run, take it to the gym, and then take it for a bike ride. Like, okay, we'll give you some of these pills, but it's so much more than just the pills. So much of heart failure and heart disease in general can be managed with health behaviors. And a lot of times, as, again, health psychologists, we all know this, the physicians might not have all the tools that they need in order to help their patients to be able to address all of these different components. And because it does take all of them at once. So I was hoping if I could do a little bit of group engagement, if you could type into the chat some of the important health behaviors that you might think about assessing among cardiac patients. Give it a couple minutes. Sleep, awesome. Yes. Diet, exercise, sedentary behaviors, that's good. Yeah, energy level, understanding fatigue. Oh, water, I saw water, that was good. Smoking, cardiac rehab. All of these are great. Yes. Awesome, thank you. Yeah, so we have, you guys even hit some that I missed on here, which is great. So of course we have all of our substances, so tobacco use, and especially now thinking about vaping, and is that okay if there's nicotine and no tobacco? I don't know. We're still kind of waiting to see what the research is going to tell us. In general, we know that people tend to use these vape pens as just a filler in between when they're smoking cigarettes. It really helps people to quit. But if it does, is that so bad to let them just keep their vape pen if they really are staying abstinent from cigarettes? Of course, other alcohol and substance use. Alcohol can be really important in this population because a lot of times people are on blood thinners. And so if you add alcohol into the mix, then obviously that can be bad, especially when we're people who have a mechanical valve. So those can be younger patients who go through valve surgery and then all of a sudden they are not allowed to drink alcohol, or it can cause internal bleeding problems. Physical activity and exercise, again, plenty of people mention that, which is great, except for that energy level, especially heart failure. People have such high levels of fatigue. So reframing a little bit about what exercise and physical activity really means in this population. Like going for a walk around the block might be huge. Making sure that you're thinking about how many flights of stairs somebody has in their house, especially after surgery or any other sort of procedure. And, or if they're going into further into heart failure, is it possible to move the bedroom from the top floor down to the main floor? Diet is important. Somebody mentioned water intake. That is huge, especially for patients with heart failure. And the other component of that is sodium, right? We want to make sure that you're not ingesting too much sodium, which is going to hold on to water. And that all can just mess up how you feel. It messes with the medications and so on and so forth. Medical adherence. We kind of touched on this, but patients are on so many different medications that need to be taken at different times, that maybe they need to be adjusted day to day based on whether somebody's gained or lost weight due to water gain and water retention. And they might need to be on, as I mentioned, 3 medications just for blood pressure. And then they've been doing a lot of work in this area of trying to do combined medications where there's like a blood pressure and cholesterol medication in one, for example. And that's been really helpful, but it's still, those tend to come with more side effects and are prescribed to a smaller sliver of the population because it's still something that they're not quite as sure about. So hopefully there's more of that coming down the road. Then there's coming to all of their appointments, especially when somebody has heart failure or more advanced cardiovascular disease, they're going to have a lot more appointments. And so even getting in to see the health psychologist, when that might be one of the more important things that they're doing because we're covering so much, it's really difficult for them to do. Or if they're coming to a place like Northwestern, which, you know, has the whole team here, but they're not able to get downtown, or we serve a population that, you know, lives maybe 4 hours away, or especially some of our transplant patients might come from out of state. So that can be difficult to assess how somebody's going to do with that up front. We need to think about how they're communicating with the medical team, and we want to make sure that they're involved with their medical care, but also listening to the guidance of their team and working with the team rather than just being a passive participant or being too much on the other side where everything they read on the internet and now they're their own doctor. Other things we want to know about is if they've had any problems with previous hospitalizations or medical procedures, because if they, after a couple of days, just got so antsy they left the hospital, then that's obviously not great, and we would want to make sure that we're working with them to help them to understand why it's important for them to stay in the hospital until they are discharged. And then, of course, psychiatric functioning and social support are going to be hugely important. So psychiatric functioning, how they're doing right now, any significant history, you all know this. And then social support can be really important for helping to mitigate any of those other sorts of risk factors. If they have someone who can bring them to appointments, if they have a wide network of family members, neighbors, friends who can bring them to appointments, help them cook healthy meals, take them for a walk around the block when they're scared to leave the house because they're worried they're going to get shocked by their ICD. So just many, many things that need to be addressed. Some are a little specific to cardiac populations, but again, this is general health psychology. So I always like to focus on adherence. I think adherence is extremely important. So I already touched on some of these. Apologies for the repetition here. But when we're thinking about adherence to medications, we want to make sure we're asking patients about what medications they're taking. Can they name them? Can they tell me what they're for? Are they taking the right dose? Does the dose change during the day? Are they taking it at the same time every day? Are they timing it around food and water intake as appropriate? And are they reporting any side effects that they might have from the medications, or reporting when they miss a dose of their medication and asking what to do about that? Do they know what to do if they miss a dose? Like, do you wait for 4 hours, and at that point you would just wait until your later dose? Do you double up on your later dose if you missed your earlier dose? I want to know all of that about what they understand about the medications that they're taking, because again, they're taking so many, it can be really difficult to keep track, and that can often be a really empowering thing for them to understand all of the different medications that they're taking. Symptom monitoring is really important, especially in heart failure. So we encourage them to take their weight every day, every morning, so that they know if there's any water retention. We want to make sure that they're monitoring their blood pressure. So if they miss a dose of their blood pressure medication, that's one of those symptoms that responds every day. If you miss your medication, then your blood pressure is going to go up immediately, as opposed to some other types of control over time, especially with thinking about psychiatric medications, right, which builds up in the system over time. And then a heart-healthy diet. Again, not that different from other healthy diet considerations. The only thing is really that sodium, keeping it down as low as possible, which, again, can be really difficult for patients when they're used to eating pizza or pickles or something like that that's their favorite food. Regular exercise and physical activity we've kind of talked about, abstinence from all substances, and then making sure we're addressing and considering other medical factors. If they have a CPAP, but they have a CPAP, but they're on their diuretic, and so they need to get up multiple times a night to go to the bathroom, and they don't want to take their CPAP off or put it back on every time more often. So problem solving with them, can they move it closer so that the cord reaches all the way into the bathroom? Things like that. Okay, so again, if I could have you all play with me and play this game here. What percentage of heart failure patients do report good adherence? So this is more than 80% of the time across all 8 domains of heart failure self-care, self-management. And these 8 domains include exercise, diet, daily weights, alcohol, sodium, smoking, the symptom monitoring, and their medications. You had to guess A, B, C, or D. Okay, so you all kind of saw where I was going, that it's pretty low, either C or D. And it is D, actually. Only 9% of patients report adherence in all 8 domains, with even giving a little bit of wiggle room for adherence. And I mean, this is hard. This is really hard. And again, just goes to show how much room we have to work with this population. Okay, so again, if you can identify what are some of the psychosocial factors that might influence adherence. So just knowing that this adherence piece is so important. What are the things that are contributing to poor adherence? Depression, absolutely. Education, family, social support, family conflict, anxiety, couple social supports, finances, and access, absolutely. Culture, good. Yeah, comorbidities, awesome, great, thank you guys. Absolutely. So all that you said and maybe a little bit more. So all those medical comorbidities and physical symptoms that they're trying to manage all at the same time, all the different medications and all of their unique side effects. Oh, ambivalence, I thought that's really interesting, definitely. And not even necessarily ambivalence sometimes, but maybe also lack of understanding, right? Of not being sure why it's important to take this medication at the same time every day. Like, why are my doctors so worried about that? And so I'm not sure if I'm willing or able to follow that unless I have a better understanding. That's a really good one. Appointment scheduling. Most appointments, I mean, now we're doing a lot of virtual delivery of these services, but even thinking about most appointments being between 8 and 4 p.m., if somebody's trying to hold down a job, that might be difficult to get them in at a certain time, especially if they're coming to so many or have monthly appointments. Like, that can be a lot of time that they're asking to take off of work. It's influenced by how comfortable they feel with the medical team, how much they trust the medical team. This especially plays into health disparities, where we know that people of color tend to be more comfortable with when they're working with a physician who is of their same background or ethnicity. Substance use, of course, is going to play into this. Any cognitive deficits, so the heart pumps oxygen to the brain, which helps with your cognitive functioning. So people with heart problems might not have the best working brain all the time, especially with heart failure. And, you know, it's not that they have dementia or amnesia or anything like that. It's just that like, their brain might not be quite as quick. It's similar to what people talk about with pregnancy or with cancer treatments, right? Where it's just like, I don't know where that went. Of course, any psychological factors of depression, anxiety, and stress can interfere. And again, some of that is with the cognitive processing itself, or just with getting to the hospital when you're feeling so depressed it's hard to get out of bed. Health literacy is important, thinking about if somebody's feeling really overwhelmed by their appointment, or they don't even know how to check their MyChart, or any of those factors can interfere with how they're adherent. And what's really tricky here too with adherence is that the people who think they're adherent but they're not adherent are often the most dangerous. Like they have just enough confidence to make it really difficult for themselves because they don't know that they need to call about a side effect. They don't know that they're taking their medication once a day when it should be 2 or 3 times a day. And so they don't know to ask those questions. And if the doctors are like, oh, are you taking your medications like we talked about? They're like, yes, sir, I am. And those are the ones that can be trickiest. We talked about motivation and self-efficacy as being really important, kind of resolving some of that ambivalence and feeling confident that you can manage your medications and come to your appointments. Financial limitations or considerations. There's transport to the hospital. There's the time that it takes if you have to take off of work. There's all the medications. A lot of these are out-of-pocket costs at a certain point. People might have poor insurance coverage, or they might have no way to access insurance if they don't have a partner who's still working and they needed to quit working and haven't been able to get on Medicaid or Medicare yet. Transportation kind of falls into that, and then ever important social support. If we don't have a good team around our patients, it can be really, really difficult to help them get the treatment that they need. Okay, so we'll dive into these a little bit. So I mentioned health literacy, and especially people thinking that they're taking the right amount of medications or when their medications as they're supposed to. What we see here is this is a small study, but this is looking at patients who correctly estimated the number of medications that they were taking when they came into the emergency department in heart failure. And that number is pretty consistent, like 22-23% of patients they're overestimating. These are the people who would say that I'm taking 15 medications when I'm only taking 10 medications. Those who correctly estimated the number of medications that they were taking, just number of meds, not what the meds were, not what the doses were, and none of that, just the number of medications that they were taking, was okay at baseline, but 3 months later goes down significantly. And those people mostly switched into the category of underestimating the number of medications that they were taking. These people are the ones that are dangerous, right? Like they're the ones who aren't taking enough medications probably, that maybe they didn't fill a prescription, and because they already had 10 medications, they forgot about the extra 5 that were actually given to them by their doctor the last time they saw them, and is just really tricky to work with. Okay. So then I'm going to talk a little bit more then about the psychological factors actually playing out in patients who already have been diagnosed with some sort of cardiac problem. Okay, so I mentioned earlier that any sort of psychological conditions, they're all associated with increased risk for developing cardiovascular disease. And once somebody has cardiovascular disease or any of these cardiac conditions, people are at much higher risk for having, especially depression. And I'm going to focus mostly on depression because A, that's where most of the research is. B, it's highly comorbid with any other psychiatric condition. And C, because it actually does seem as though depression is more important than other psychiatric conditions, especially when compared head-to-head with anxiety, where they might both contribute to poor health behaviors in this population or lack of adherence in this population. But depression almost always has a greater role than anxiety does, even if they are both significant predictors. So almost half of some of these patients, up to 40%, is a pretty consistent number after somebody has a heart attack among people who are diagnosed with heart failure or just general coronary artery disease. And I apologize for using so many abbreviations. So coronary artery disease here, implantable cardioverter defibrillators, so that the ICD that shocks your heart, after having an MI or a heart attack, after going through cardiac surgery, or after being diagnosed with heart failure are these elevated rates. And we can see that it's pretty high for just elevated depressive symptoms, but then still a really high proportion are meeting criteria for major depressive disorder. And having heart problems increases risk for depression, as well as the reverse, which we saw before. So this is an example from a cardiac surgery population, and I chose to focus on this because you actually do have before, during, and after sorts of looks at this. So what this is showing is that people who did not have depression beforehand had an increase in their high levels of depressive symptoms, okay? People who were at risk for depression also saw an increase in depressive symptoms after cardiac surgery. Whereas, interestingly, those who were depressed beforehand saw a small decrease in their depressive symptoms after they had cardiac surgery. So this is something to be mindful of, that when people they might not have the traditional risk factors for depression, and that's actually something I'll touch on in just a couple of slides. But basically, anyone going through cardiac surgery is kind of at risk. It's helpful to watch out for them of developing depression after surgery. And this is just a discharge, right? We're not even talking once they go home and have trouble moving around or need to go to cardiac rehab. This is just a discharge a couple of days after surgery. Okay, so we also know that depression is associated with, or having a heart attack is associated with then developing depression. So what are the odds of all-cause mortality among heart attack patients who have depression compared to heart attack patients who do not develop depression? 1.5 odds, 2.4 odds, 3.0, or 4.1. All over the place with B, C, and D. So it's actually B. Oops, I didn't highlight that one, sorry. So the odds of someone dying all-cause mortality after having a heart attack goes up by almost 2.5 times if somebody has depression versus if they don't. Okay, this is all people who have heart attacks. Your odds of dying, again, all cause, not cardiac specific, just of dying because you have depression is increased by 2.5. Like, that's huge. That's a huge impact that depression is having on the heart. Okay. And I think this is my last one. So we also know that there's this association between depression and heart failure, right? Up to 40% of patients with heart failure have elevated rates of depressive symptoms. So what is the rate of one-year mortality in heart failure patients with depression compared to those who don't have depression, which is already a 14% mortality rate for those who don't have depression? Okay. All right, seeing lots of C's and D's here, and C is correct. So again, it's just, there's such a strong impact of depression on the heart. And Olivia, who I see is on the call, and I actually just wrote a little bit about this, about how depression impacts the biology and causes heart problems. I'm not going to get into it here. If you're interested, I'm more than happy to discuss it later, but this just goes to show you just how much of an impact that depression is having. And if we can help these patients to feel a little bit better by improving health behaviors, improving adherence to medications, helping them find that social support, we can potentially have a really big impact on this group. So just to kind of give you an idea, other things that we see associated with depression among those with cardiovascular disease, they're more likely to have secondary events, another heart attack, or have problems after surgery and they need to be admitted to the hospital. They're in the hospital for longer, and of course, greater healthcare expenditures associated with all of the above. And again, we've been talking about adherence, but depression is the single best independent predictor of non-adherence, right? And so even I've mentioned medications, that even just looking at taking a single aspirin, daily aspirin, which is a really common treatment, and a lot of people do it preemptively, which is great. So there is this difference of more than 20% of people who are taking their daily aspirin if they don't have depression compared to those who do have depression. Just a single pill once a day, a small one, right? Sometimes they're taking these huge pills and lots of pills. Even just the daily aspirin is influenced by depression significantly. Depressed patients are more likely to drop out of cardiac rehab. And then here we see that those with persistent depression have even poorer adherence to health behaviors that we've already talked about, right? They're more likely to be smoking. They're less likely to be adherent to their medications, less likely to be engaging in regular physical activity or exercise, less likely to go to cardiac rehab. Diet is borderline, but trending in the same direction. And among patients with coronary heart disease, in this case, this is among patients in the Heart and Soul study, we see that depressive symptoms at baseline also are predictive of worse health behaviors 5 years later. So it's not just in the moment, but it's over time. And we see that especially things like physical activity and poor sleep quality and smoking are significantly impacted by depression, even with this 5-year difference. Okay. So that was my whole spiel on depression, but of course, anxiety and other psychological conditions are still important. So here we see that the prevalence of these various anxiety conditions are all significantly higher than the prevalence in the general population. So even things like phobias, and it's not just generalized anxiety disorder, are all really important to consider in these populations, because again, we know that they can influence adherence. We know that and sometimes it can be helpful, right? If somebody is anxious and they're in greater contact with the healthcare system, but then we might be worried about them causing the team distress, the medical team, and making sure we're working with the patient about what's an appropriate level of contact and how to communicate when somebody's feeling anxious. Oh, and of course, anxiety and depression are highly comorbid, and we know this in the general population. This is also true among patients who have any sort of cardiovascular disease. Severe mental illness is another one. So 10% of people who have severe mental illness, even around middle age, have cardiovascular disease. And there's also a high incidence of cardiovascular disease that develops pretty quickly after onset of severe mental illness. And so compared to those who were the psychologically healthy controls in one study, adults with severe mental illness, and I'm sorry, this is a large scale meta-analysis of like 3 million patients that they were looking at, and it includes patients who have schizophrenia, bipolar. It does include major depressive disorder and other related spectrum disorders, compared to 113 million controls, so huge study. And they found that those who had severe mental illness had over 50% higher risk for having cardiovascular disease, nearly 80% higher risk for developing cardiovascular disease, and 85% higher risk of dying from cardiovascular disease. Okay, so I want to be mindful of the time. So again, I kind of mentioned that assessment and treatment, of course, there are things that are specific to cardiac populations. A lot of it are things that we already touched on. So I'm going to breeze through these a little bit more and make sure we have some time for questions, but feel free to stop me or put in a question that we can get to at the end. Okay, So a lot of the work that I ended up doing in cardiac behavioral medicine was on the inpatient unit, and we would get consults. I was in the division of surgery, of cardiac surgery, and so we were working a lot with the patients who had just had surgery or maybe were in-house and needed surgery and working with them before that. So a couple of specific things that you want to make sure you're assessing in these patients is how they're coping with the hospitalization, how they're doing communicating with the medical team, especially your team might be changing every day. You have different nurses, or a PA comes or a medical student comes in and asks you all the same questions that then the resident and then the fellow and then the attending is going to ask, and how are they coping with that? How engaged are they in their care? Because again, somebody who's just a passive recipient in the hospital, we want to make sure that they're able to take home all of the information and skills that they need to be able to be more active in their care, especially once they are going home, and empowering them that they do have some control over what's going on while they're in the hospital. Understand if they have any passive stress management activities. So if we have people out there who love going to their exercise class or going for a run in order to release stress, that might not be a great option in the hospital. And so maybe we can find them some coloring books or puzzles, or maybe people like reading really long books, but they're mentally just not able to really focus on that, or they're too tired to engage in a dramatic storytelling. So maybe helping them find a magazine. And I love to tell people that the hospital is the best time to catch up on celebrity gossip and read those trashy magazines that they would never otherwise read, because it's just easy on the brain. Seeing what type of social support they have, both while they're in the hospital and, of course, once they go home. If there's any relevant phobias, especially blood injection injury, and I already mentioned claustrophobia, if they have to have any special imaging done. How their sleep is, because it's almost always terrible in the hospital. And so if there's a way that we can allow them some more interrupted sleep time, or if they need a sleeping aid, some medication while they're in the hospital, that's often very reasonable in this group. And then any adherence concerns we have. What was it that got them into the hospital? Was it because they ran out of their medication or deliberately stopped taking their medication, and that's what landed them here? And if they aren't following up with medical appointments, seeing what we can do about getting them to come back after they're discharged. It's also important to make sure that we're thinking about delirium as a potential influencer here too. Sometimes the medical team doesn't catch this. They're just like, oh, they're really sad, or they're just acting really weird. And so that's something where, again, psychologists and psychiatrists in particular actually can be really helpful in identifying delirium so that it can be treated. On the outpatient side, again, very similar. We already talked through a lot of these, but essentially I go through presenting problem, helping them to understand their disease, and I want to know what they understand about their disease and what gaps I might be able to fill in, any family history that they have and how those people that they know coped with it, or if they died from it. That's important information. I want to know what their treatment history is and any plans for upcoming procedures or treatments or changes in medications. If they had any difficulties with medical care and working with the medical team in the past, if they switched hospitals because they weren't getting along with their medical team, sometimes that's totally fine and appropriate. Like, we want to make sure that everyone is comfortable with the care that they're receiving and trust their medical team. And it might be helpful to get a little bit more information about what happened and if there's something that we can do to prevent that from happening again. And of course, health behaviors and any recent changes in health behaviors. And for heart failure therapies in particular, and I can't remember, but I'm pretty sure you have someone who's speaking with you either already did or at a later date about transplant psychology. And so this is very similar. And the important part is really, I want them to understand. I want them to be able to tell me what they know about transplant, about the process, and about the ventricular assist device. What are the changes that they're going to have to make to their lifestyle afterwards? What are their odds going into surgery of survival, right? I want them to go in with an open mind to this. A heart transplant is not a silver bullet. You are trading a heart failure problem for an immunosuppression problem, right? And that's something that you have to manage for the rest of your life. I want them to know what resources are available to them. I want them to be able to identify all of that really critical social support. I want to understand their full history of adherence because especially with transplant, having to take their immunosuppression medications twice a day at the same time every single day, I want to make sure that's something that they feel capable of doing. Substance use history, of course, for anything that might come up and any relapse they might have, especially if they start feeling better or if they are feeling terrible and need that to cope in the past. I want to know about that, and just general social history as well. Okay. Again, I'm going to go through these very quickly. So specific interventions, of course, there's a ton of psychoeducation. There's a lot of validation of the experience that they're having. There's general stress management and relaxation strategies like you might use with any other patient population. CBT, ACT, mindfulness, these are all great strategies to use. And I personally think that the most important work that I've done with patients is helping them to recognize that they have choices, that there's a lot within their control, and helping them to identify what are those choices, what are the consequences of making this choice versus that choice, and bringing in that health literacy piece of providing that education as many times as needed, explaining it to them, having them explain it back to you. And rather than just writing a prescription and saying, do this or do that, or don't do this or don't do that, really trying to get that understanding out of them. And for health behaviors in particular, of course, we have our SMART goals, identifying barriers and helping them to problem solve, following up, assessing, and adjusting as needed. Follow up every single time, because if there's something about their medical situation, their symptoms change, that's going to impact how they're feeling and able to engage in those healthy behaviors. And repetition, repetition, repetition. And this is, at least for our program, there's a ton of resources available for these patients in different places. We will often give them scales if they don't have one at home to keep track of their body weight. If they, there might be GoFundMe pages that can be set up, pill boxes to help them organize their medications, various Medicare services or insurance case managers that can help them out. And then, again, this is a resource that I'm happy to send out from the American Heart Association about heart failure in particular that I think patients find really helpful. And just a quick note about psychiatric medications. SSRIs can be potentially tricky in this group because some prolong the heartbeat in ways that it is not helpful for this group. And then use of benzodiazepines also can lead to delirium. And herbal supplements, we obviously want to know about anything that a patient is taking that might otherwise interfere with their diet, especially again thinking about heart failure and that fine balance of sodium and water retention. So these are all really important things to assess in this group. Okay, I don't really have time to go into this, but it's so important to work closely with the whole multidisciplinary team, working with all of your physicians and nurses and pharmacists, social workers, and of course, working with the psychologists. So just a shout out to the amazing teams that I've worked with over the years who helped train me and help me take care of my patients. Okay, that is all. Thank you all so much for your time and attention. I am happy to take a few questions. Yes, I can share the PowerPoint. I can send that to Zoe and you can send it out. Is that okay?
Is it the same PowerPoint that you used last time, or are there some changes?
I made a few edits, so I'll send it
so just send me the new ones. Okay. You know, if we don't have any other questions, one that I was just wondering is, you know, during internship and postdoc, what were some of the key training experiences that you feel like helped solidify your direction in psychology and your career?
Yes, that is a great question. So for me personally, it was getting to work on research projects for the patients that I was working with. So not necessarily in a clinical trial, but for example, I did a program evaluation or QI project of cardiac rehab participants, and they were I saw some of those patients in the behavioral medicine clinic and referred them to cardiac rehab or got a referral from cardiac rehab. And so looking at how depression influenced cardiac rehab participation was something that I really liked, finding that connection between what I was doing with the patients that I was actually working with in the room and being able to have a balance of that one-on-one, I'm making a difference with this patient, and also more broadly contributing to research and helping to progress the field because I had that clinical perspective.
Thank you. Yeah, I can see what you mean when you talked about your research experience with, brain imaging being too far removed. It seems like you love the both ends of like the one-on-one and applying it to a broader population.
Absolutely.
Hi, Allison. Thank you so much. Can you hear me?
Hi, Sarah.
Hi. Thank you so much for the great presentation. I came in a little late, so forgive me if I missed this, but I remember learning that, and this was probably it predated some of the studies that I saw you had in there, that the best predictor of a second MI was depression after the first MI, even more so than other physical markers like the degree of infarct or other things. And that, it sounds like that still holds true, and that the behavioral factors could be the driving force behind that.
Absolutely. Yes. I do believe that is still the accepted truth at this point. And yes, it works biologically. Like, we know that there's so many effects that depression has on the body's ability to function and how that impacts the heart. And then, of course, through those behavioral mechanisms and social mechanisms, if they're withdrawing socially because they're depressed and it's harder to engage with friends and family like usual. Yes, there's so many ways about it. And if we can address depression, we can hopefully have a much broader effect on all of those other components.
That's amazing. And do you feel like this knowledge about the impact of depression on outcomes, is that well known among cardiologists? Are they pretty savvy to that as well? And
that's a good question. It's hard to say because I've always worked in settings where there was a psychologist. And so I'm curious if that's as well known among cardiologists who don't work with a psychologist, who have never had that experience. I would guess it's not as well known. And I've definitely seen it when working with our fellows, for example, who come through their heart failure fellowship or Advanced Heart Failure Therapies fellowship. And from the beginning to end, the change that you see in how much they refer, and when they come and seek you out to ask questions about how to manage this difficult patient for whatever reason, is drastic. So I think there is a lot to say about exposure. So I think it's probably under-recognized still.
And do you feel like that's dependent on the hospital where they trained? And
yeah.
Do you feel like they would get that in every fellowship, or no? Northwestern just has a particularly good cardiac psychology.
Yeah, there's very few that are specifically housed within cardiology or cardiac surgery. There's a lot of behavioral medicine programs that might have someone who specializes in cardiology or transplant, for example. But yes, it's pretty unique at Northwestern, which was a great training experience, but is not the reality of the world.
Yeah. Do you feel like it's advantageous to be housed under cardiology versus separately?
That's always been my preference. There's certainly pros and cons, and I guess I always like to specialize. I like to kind of get deep in the weeds and make sure that I really know the language and know the research and the literature really well, as opposed to a more broad-based behavioral medicine. And and I think it does help with that multidisciplinary teamwork if you're right there and the team knows that you're available and that you're housed there and in all of the same email chains as they are. I think that's really helpful.
Thank you.
Mm-hmm.
If we have another minute, I did have couple other questions. One of them was that you said with mental illness and cardiovascular disease that, there's a much higher risk of cardiovascular disease among people who have severe mental illness.
Mm-hmm.
Is that true even after controlling for behavioral factors? Like, is there something about the common biology, or is it that they're more likely to also use nicotine, or that they're more likely to also be overweight?
So I'm not sure if they controlled for that in the specific study that because I don't know if they just had all that information on that large group of people. But I do know that they have shown that mental illness across all of these, of depression, anxiety, and severe mental illness, they've shown that it really is above and beyond all of the behavioral factors. Yeah. Mm-hmm.
And I again, stop me if you already talked about this, but it seems like a heart attack, for example, would meet criteria for an event that could lead to post-traumatic stress disorder.
Mm-hmm.
Do you find that? Is that, like, for example, motor vehicle accidents,
right,
there's a high rate of PTSD following it. Is it the same with a heart attack?
So it's always been less than I expect, honestly. It's more about if they have a traumatic experience in the hospital, I would say, or where, for example, if they're like aware of something, but they're like a little paralyzed or still anesthetized, but they're cognitively aware, that's the most traumatic experience. So I'm trying to think. It's usually more associated with the hospital and just the hospital setting. So it might be linked to a heart attack, but it might be cardiac surgery or just any other sort of hospitalization experience that tends to show up more. And this is all anecdotal.
Yeah, that's cool. Thank you.
Yeah, no, that's a really good point. And I think we are recognizing, obviously, trauma. Oh, yes. Thank you for sharing that about PTSD and cardiac disease. So yes, that is, we're recognizing for sure the influence of trauma symptoms and traumatic experiences and PTSD, of course, in cardiac populations. Absolutely. And thank you, everyone, for all of your kind words. I'm so honored.
It was great, as everything you do, Allison.
Well, I was trained by the best.
Oh, I'm so lucky. I still, in fact, Allison set up our whole smoking cessation program, the Chicago VA, and I think you were more of a mentor to me than, but I loved it. Everything you do is always fantastic.
You're too kind. It was very mutual. I loved it. I'm so glad I did that externship. That was it's so great.
I miss you. Too bad